I would like to acknowledge my mentor, Dr. John Knight, for the use and development of these slides, as well as the staff at the Center for the Adolescent Substance Abuse Research Center, or CSER, at Children's Hospital Boston, and my colleagues at the New England Partnership for Substance Abuse Research, also known as NEPSAR. I have nothing to disclose with this presentation. Why do we care about substance use in adolescence? We will discuss that initially as to why it is important for the primary care provider. Following that, I'll give a brief description of some substances that are commonly used by adolescents, and then get into the meat of the talk, which is regarding screening and assessment of individual teenagers, as well as how to perform a brief intervention, and then briefly discuss referral to treatment. Motor vehicle crashes are amongst the leading causes of mortality for youth ages 15 to 24 in the United States, at 23% of all deaths in 2011. Other unintentional injuries, such as drownings, comprise 18%, homicides 15%, and suicides at 16%. This means 72%, or almost 3/4 of death in the youth age group, are entirely from preventable causes. Alcohol involvement is often found in fatal motor vehicle crashes. Approximately 22% of drivers under the age of 20 involved in a motor vehicle fatality in 2010 were found to have a blood alcohol concentration of greater than 0.01. Remember that an alcohol concentration of greater than 0 in this age group is completely illegal. However, the mean blood alcohol concentration of those drivers under age 20 involved in motor vehicle fatalities was 0.12, which is well over the legal limit of 0.08. The Youth Risk Behavior Surveillance System was started in 1990 by the CDC and surveys public high school students every other year at randomly chosen high schools throughout the United States. Many communities have also adopted doing their own youth risk behavior surveys. Across the United States during the past 30 days and the YRBS from 2013, approximately 35% of high school students reported doing any alcohol drinking at all, and 21% reported binge drinking, which is 5 or more drinks in a row within a couple of hours. 10% of high school students reported that they had driven a vehicle after drinking, and 22% reported riding with a driver who had been drinking. Marijuana also affects driving as well. It can affect concentration, perception, coordination, and reactive time for folks behind the wheel. And these effects can last up to 24 hours after patients have been smoking. Therefore, marijuana use increases the odds of unsafe driving by about 30%. There are many correlates of substance use during adolescence that have been found in multiple research and correlation projects. These include, as outlined previously, injuries, either intentional, such as fights or homicides, or unintentional injuries, such as drowning. Emergency room visits may be secondary to overdose. School failure, increased levels of violence, increased levels of arrest and incarceration, possible brain damage secondary to overdose or heavy use. It can also cause increased numbers of sexual assaults, which may lead to unprotected intercourse, increased risks of sexually transmitted diseases, HIV and AIDS, and possibly fetal alcohol syndrome. This slide demonstrates the prevalence of lifetime diagnosis of alcohol dependence by the age of onset of alcohol consumption. For people who begin drinking at age 13 or less, they have approximately a 47% chance of having a lifetime diagnosis of alcohol dependence, compared to people who start drinking at age 21 or greater, who may have only a 9% chance. This very complicated slide does demonstrate some substances used by 12th graders. Alcohol is the most common substance of choice, including ever drinking alcohol, as well as ever having been intoxicated. Any other drug comes second, followed quickly by marijuana or hashish, which is at 42%. The other drugs that are commonly chosen are outlined here, including prescription drugs. So what are the goals of SBIRT? Well, the first goal is to determine in your office if a teen has ever used any substances at all, alcohol or drugs. And then to determine if the teens who have used are at very high or low risk for abuse. We also like to give positive feedback to any teens who abstain from the use of alcohol or drugs and give health advice to those youth who are at risk. Finally, it is appropriate to refer high-risk teens to interventions to be able to assist them with their substance problem. So what are some definitions? Well, the definition of a screening is a procedure that is generally applied to populations, meaning every patient who comes to the office, that's intended to identify individuals that are at risk for a particular disease or condition. So first, we will discuss screening. Multiple studies and polls done by the American Academy of Pediatrics have found that fewer than half of pediatricians report screening all of their adolescent patients for use of alcohol and drugs, and fewer than a quarter of pediatricians report screening for drinking and driving. However, in the past, brief interventions and motivational interviewing have not been well studied amongst adolescents. Also, resources for adolescent substance abuse treatment are quite scarce. What are the top 6 reasons that providers give for not screening their patients in the office? Number 6, providers may not be familiar with the appropriate screening tools. Today we will discuss the acronyms used to be able to remember the questions to correctly ask all adolescents. Number 5, a very tenacious parent who won't leave the room. Providers often feel that if they have a parent present, they won't get accurate information from teens and therefore do not bother screening at all. Number 4, providers often note that there is a perceived lack of treatment for their adolescent patients who may suffer from substance abuse problems. Therefore, why bother screening them in the first place if we don't know what to do with them? Number 3, the need to triage any competing medical problems. In a 15-minute visit, there may be multiple issues going on that need to be addressed. Number 2, providers feel that they don't have any training to be able to deal with a positive screen that may come up in the course of the office. And the number 1 reason that clinicians give for not screening their adolescent patients? They don't have enough time. There is a lot going on that is compressed into a very short visit, and often substance abuse screening falls by the wayside to address other issues. This mnemonic demonstrates how to take an appropriate adolescent social history, and it was created by Drs. Goldenring and Cohen from the University of Southern California. What is nice about the HEADS acronym is not only does it help us remember all of the appropriate social history questions to ask, but also helps to establish rapport with the patient while you are in the room with them. The first H, which is home, for most teenagers, not all, but for most teenagers is actually a pretty safe topic to begin with discussion. And then moving forward through education and employment, as well as any extracurricular activities. And then specifically talking about the sensitive questions such as drugs, diet, and moving forward into sexuality and suicide/depression. When we are doing substance screening within the drugs section, we can use various screening methods. Some providers prefer to provide written questionnaires for their patients to complete while they are waiting to be seen. Other providers like to ask their patients questions directly. In this day and age, electronic devices may also be used to screen patients. It's important to start off by asking about peer and any family use of substances. And specifically, I like to use the question, do any of your friends, or do you know anyone who uses alcohol? Do you know anyone who smokes? Can be very helpful to break the ice with a patient. Finally, you wish to ask about a patient's lifetime and current use of substances using 3 very specific questions. First, have you ever drunk alcohol? More than a few sips. Second, have you ever smoked marijuana? And third, have you ever used any other drug to get high? If the patient responds yes to any of these questions, then you move forward to asking them the specific questions of the CRAFFT screen. The CRAFFT questions are as follows. C, have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? R is probably the most common positive answer I have seen, and that is, do you ever use alcohol or drugs to relax, feel better about yourself, or fit in with your friends. Again, because alcohol use or drug use is social for teenagers. A, do you ever use alcohol or drugs while you are by yourself or alone? Again, can get at substance dependence issues because of the alcohol or drug use being social for youth. F, do you ever forget things you did while using alcohol or drugs? May get at some binge drinking or other blackout type behavior. Second F is, do your family or friends ever tell you that you should cut down on your drinking or drug use? And this is similar to the C of the CAGE questions. And then finally T, have you ever gotten into trouble while you were using alcohol or drugs? Now this question can be open to interpretation. It may mean that the youth's parents found out and they were grounded for 2 weeks, or it may mean that the youth did something that they would not otherwise have done if they were not under the influence, perhaps had sex with someone or got into a fight. This is how we score the CRAFFT screen. The positive predictive value is noted here. If a patient has 6 positive answers to the CRAFFT, then they virtually have a 100% chance of having a diagnosis of drug abuse or dependence. However, if they only have an answer of 1, they may only have a 25% chance of having a diagnosis of abuse or dependence. So what cutoff do we use to determine their risk? Well, it's been found that the highest sensitivity and specificity come with a CRAFFT score of greater than or equal to 2. This has a reasonable sensitivity but a very high specificity, which will then go on to prompt us to ask any additional questions. This has been demonstrated in a study that was done by the New England Partnership for Substance Abuse Research that looked at various clinics throughout the Northeast. This slide demonstrates the results of those data at several different centers for patients that were at risk because they had a CRAFFT score of greater than or equal to 2. So let's talk about a specific patient. This is Jim. Jim is 16, and he's in his junior year at the local town high school. Jim was diagnosed as having attention deficit hyperactivity disorder when he was 7 years old and is currently taking methylphenidate. He's quite pleased because he made the varsity basketball team this year, and he's coming to the office now to get his sports physical. Jim says that school is actually going pretty well this semester. His grades have always been in the B to C range, but states that he's been steadily averaging a B average for this past term, and he's happy that he made the honor roll this time around. As part of your screening, you decide that you're going to ask Jim about alcohol and drug use. So here's Jim's CRAFFT. For the car question, Jim answers no. He has never actually ridden or driven anyone under the influence of alcohol or drugs. For R, he says, yes, actually, he's at a party, he will often drink or smoke marijuana to fit in because that's what everybody else is doing, and he doesn't want to look awkward. A, has he ever used while he was alone? The answer is no. F, forget. Jim, when thinking about it, states that once he did forget after he and his friends had been using substances what movie they had watched. His friends and family or family, yes, Jim drinks more than his friends, who often tell him he should slow down. His parents are often not aware of his use. And then finally, T, has Jim ever gotten into trouble because of his substance use? No. Okay, so we have now screened Jim, and we have to move forward to doing his assessment individually. An assessment is a procedure that is generally applied to individuals, intended to confirm the presence of disease, measure its severity, and help us in guiding our treatment planning. So let's move forward into discussing assessment. An assessment is a much more detailed substance use history for an individual patient. It's also very important to screen for any coexisting problems, such as mental health issues or social problems, such as family concerns. Additional elements that might be helpful would include collateral reports, perhaps from teachers or friends, or often I will also ask college roommates if they have any input, if the patient gives me permission to do so. In addition, it's important to take a detailed family and individual patient's psychosocial history. Well, there are multiple ways that you can interview. The first and often more commonly used interviewing style is that of the Sergeant Friday, which is asking very blunt, closed-ended questions, like, how much? How often do you use? Where'd you get it? These very closed-ended questions result in a very cold, distant interrogational style that is not well received by many youth. It's often summed up by the phrase, just the facts, ma'am. Instead, the Lieutenant Columbo style is a little bit more about mutual discovery and problem solving. Sort of the, well, I'm not quite sure I understand. Can you help me out here? Asking very open-ended questions that are empathic, such as, well, what happened when you did that? And when that occurred, how did that make you feel? And why did you feel that way? In other words, it's a very open, empathic style, which often many more teens will open up to. It's very important to express guidelines with a youth when you are taking their substance use history. It is key to explain any ground rules of confidentiality. In general, all information that a youth provides you should be considered confidential unless their safety or the safety of others is at risk. If it's important to break the confidentiality, the adolescent must be included in a discussion of how to tell parents or others. And it's also very important to let a youth know that you will let them know before you go to their parents or guardian to break their confidentiality. It is critical to interview an adolescent privately to get accurate answers, and crucial for us as providers to leave any judgments that we may have about their substance use at the door. Again, this slide does appear to look like closed-ended Sergeant Friday type questions, but it is really just meant as a guideline for the information that you would like to gather. So what's very important to determine is when the patient first began using, how often did they use it first compared to what they're doing now? What do they like about using alcohol or drugs? If it were completely negative, nobody would ever do it. So there are positives that individual patients might have for why they use substances. But follow that up quickly with what don't you like about your alcohol or drug use. Have you ever tried to cut down or quit? And have you ever had any problems such as the use, such as accidents, legal problems, any issues with school, personal injuries, or difficulties getting along with others? Some risk factors for substance use, abuse, and dependence would include the following. First, genetic. Much more common against white males with a family history of alcoholism or other substance use. Their familial and socioeconomic status, such as a higher SES, which may allow adolescents to have more money to be able to use, as well as having any active substance abuse in their family. Third would include environmental factors, such as their peers, how easy it is for them to obtain alcohol or other drugs, as well as acceptance within their community. Fourth, any psychiatric comorbidities that may cause patients to wish to self-medicate, and these often include any mood or anxiety disorders, post-traumatic stress syndrome, obsessive-compulsive disorder, and attention deficit disorder. And then finally, poor school performance. And of course, the concern always is, are they using alcohol or drugs because they're performing poorly in school, or are they performing poorly in school because they're using alcohol or drugs? This complicated slide demonstrates various stages of use of substance. I'm not going to walk through it in detail other than to say that it can be fluid through most of the usage. All patients start off in abstinence. Some choose to move forward to experimentation but may stop there. Others progress to regular use, which is occasional social use with their friends, which again, they may stop there or return to abstinence, but otherwise might escalate through problem use, abuse, and dependence. Alcohol or drug abuse includes one or more of the following. Failure to fulfill obligations at work or school or at home, such as repeatedly getting suspended, frequently being absent from school, not keeping up with chores that they're required to do at home, etc. The use in very physically hazardous situations, such as drinking and driving, or riding with someone who has been drinking. Any substance-related legal problems, such as arrest, or continued use despite any social or interpersonal problems related to their substance. They keep having problems getting up for school and know that this is a problem, but continue their substance use. In contrast, alcohol and drug dependence requires 3 or more of the following. A tolerance to the substance that's being used. The patient finds they need to use more and more of it to get the same effect. They may have withdrawal if they stop using abruptly. Patients may find that they are taking substances in larger amounts or for longer periods than intended, often going on what's called going on a binge or a bender. Having a persistent desire or unsuccessful efforts to cut down or control their use. They keep trying, saying, next week I'm going to cut back, try to cut back, and are unable to do so. Patients may experience using a great deal of time obtaining, using, or recovering from the effects of the substance. Longer and longer hangovers have been noted by many patients. They may need to give up important activities or reduce because of their use. Perhaps they had been on a team for school and can't keep up with doing that anymore. And then finally, continued use, despite physical or psychological harm from using this substance. Moving forward, we will now discuss how to perform a brief intervention for various stages of risk. The effectiveness of brief intervention has actually been shown to reduce or stabilize risk for any individual patient. It's also been demonstrated to decrease drinking rates of college students and decrease substance use in younger students, too, amongst high school 14 to 18-year-olds. So let's apply the SBIRT to various levels of risk for different patients. Lisa. Lisa is a 14-year-old girl who presents for her annual physical examination because she is going to be playing soccer this fall. She answered no to all of the opening 3 questions and no to the car question. Lisa is considered to be at low risk. There is no adolescent who is at no risk for substance use, but Lisa is considered to be at low risk because she has had no use of alcohol or drugs during the past year, and she's had a negative car question. So Lisa's intervention would consist of praise and encouragement, stating something like, "I'm very proud of you. That's a smart decision. However, if it ever changes, I hope you will trust me enough to come in and talk about it." That last sentence is key because, again, Lisa is a younger 14-year-old adolescent, and as she moves through her teen years, she may be considering moving into the experimentation phase, and you don't want to over-encourage her for abstaining because she may feel that she is letting you down if she comes back to meet with you in the future and has used alcohol or drugs. Next is Rob. Rob is a 17-year-old male that's about to start his senior year of high school. He takes all honors and advanced placement classes and is interested in going to the University of Virginia next year. Rob says that he does not use alcohol or drugs himself, but once he got a ride home from a friend who'd been drinking. Rob is considered to be at medium risk because he has had no use of alcohol or drugs during the preceding year, but he does have a positive answer to the CAR question. So with Rob, it is important to discuss his risk reduction. And oftentimes we will use contracts such as the Contract for Life that has been put out by Students Against Destructive Decisions. However, there are many other contracts that may be available on the internet. This is an example of such. Again, the Contract for Life that is from SAD. This is available on the internet. There are 2 sections to be signed, both by the young person and then second by their parent or another identified caring adult. The first part of the young person's contract states that they will try not to use alcohol or drugs, but if they do, they will pledge to contact a parent or other caring adults to come pick them up if they are in a situation where they are at risk for riding with someone who is under the influence. For the parents' part, they also state that they are committed to the youth's health and safety, that they will agree also to not drink and drive, and finally, that they will agree to come pick up the young person, no questions asked, at the time of the pickup to make sure that they are able to be transported safely. This does not mean, which I say to patients and parents all the time, that they cannot have a future discussion the following day and talk about what happened. Moving on to the next patient. This is Marcus. Marcus is an 18-year-old who comes to the office after injuring his ankle at football practice. While he's there, you decide to give him the CRAFFT screen, and he states that he's been high on marijuana on several occasions, but not at the time of this injury. He says he's never used any other drugs, and his CRAFFT score is 0. Marcus is also considered to be at medium risk, but of a different type, because he gives a yes answer to the use of alcohol or drugs during the past year, but has a negative CRAFFT screen because his score is less than 2. For Marcus, it's important to give advice to stop using and discuss the health risks of alcohol and drugs. My advice for you is to stop using alcohol or drugs at all, because they pose a serious risk to your health. Then you can ask him to agree to an abstinence challenge, which is a time-limited trial of abstinence. For example, 1 week to 3 months, depending on how significant his use is, and then come back for a return visit after the challenge to tell you about how it went. Some examples of brief advice that you might give Marcus are the following. Alcohol use can really damage your liver, and marijuana use can hurt your lungs. Or, marijuana directly affects your brain, and that can hurt your school or athletic performance. Alcohol and marijuana use can cause accidents. Drug and alcohol use can lead to sexual assault, sexually transmitted diseases, and potentially unintended pregnancies. If a girl becomes pregnant, alcohol and drug use could hurt the baby. And finally, which is often quite effective for many high school and college students, using excessive alcohol and marijuana can actually make you gain weight. Finally, we have Katie. Katie's a 17-year-old girl who comes in for a physical exam. On her screening, she says that she drinks alcohol and uses marijuana every few weeks, but has never used any other drugs. She gives you yes answers to the relax, family, and trouble questions, so her CRAFFT score equals 3. Katie is considered to be at high risk because she gave you a yes answer to the use of alcohol or drugs during the past year and has a positive CRAFFT score greater than 2. It's very important to express concern with Katie and make an appointment for a follow-up to perform detailed assessment. For example, you could say, Katie, your CRAFFT score indicates that you're at quite high risk. I'm very worried about you. I'd like for you to come back again next week so we can have more time to discuss this. Ask her to agree to abstain from any alcohol or drug use until her return visit. So for patients who are at high risk with a CRAFFT score greater than or equal to 2, it's important to do a brief assessment. Importantly, you need to rule out any acute danger. So if Katie were consistently drinking large amounts of alcohol and then riding or driving with friends every weekend under the influence, at that point it might be appropriate to break confidentiality if she is having some ongoing acute danger. Secondly, you need to schedule appropriate follow-up for patients who are not drug dependent. You can then go forward and offer some motivational enhancement interviewing at that follow-up. For any drug-dependent patients, it's critical to refer to treatment, and that might be helped by involving parents whenever possible to facilitate the referral and help to improve outcomes for each individual patient. Acute safety concerns might be considered as the following. Any use of drugs other than alcohol or marijuana, consuming potentially lethal volumes of alcohol, or driving after use or while intoxicated on a regular basis. Some assessment questions that you might utilize with Katie are, tell me more about your drinking. In detail, Katie says that she started drinking at parties when she was a freshman. Now, she maybe drinks about twice a month, but anywhere from 4 to 6 shots, which is enough to get drunk. Katie, have you ever had any problems secondary to your drinking? Well, Katie says that she was suspended for a couple of weeks from soccer because she was found drunk by police who came to a party where there were alcohol. Her parents found out, got very upset, and she was grounded. She said that she would stop drinking, but actually has continued to drink regularly with her friends. Katie, have you ever had any sexual contact after drinking? Katie says that she had sex while she was drunk twice, and in fact, 2 days ago had sex while drunk and did not use a condom. You ask Katie if she's ever tried to quit drinking, and she says, no, I've never tried to quit drinking. I drink less than my friends do, so I do not think my drinking is a problem, is the response that she gives you. Some red flags for dependence are listed on this slide. They include a CRAFFT score of 5 or 6, a positive CRAFFT screen in a patient that is less than or equal to 14 years old, daily or near daily use of any substance, any history of alcohol-related blackouts, any history of a drug use-related hospital visit, such as a visit to an emergency room, a history of any intravenous drug use, or a combination of alcohol use with other sedative drugs, such as benzodiazepines. When you further assess Katie, you determine that she is a high-risk drinker, but she does not give you any red flags for any acute danger or addiction to alcohol. You decide to invite her back for a future visit to discuss her drinking and therefore being able to use any motivational interviewing techniques. To conduct motivational interviews, we often will do it on a population of adolescents who are not drug dependent to be able to hopefully make some inroads. The setting is considered to be 1 or 2 brief, maybe 30 minutes or less, individual counseling session. We use motivational enhancement therapy to ask specific questions. And who can do it? Anyone, a clinician, a nurse practitioner, a PA, or any allied mental health provider who may be present within your clinic. When you do motivational enhancement therapy for Katie, she responds by telling you that she's not interested in quitting. Because all of her friends drink, she cannot imagine being the only one not drinking at a party, and that would be very embarrassing. You push a little bit further and ask Katie would she consider to cut down, and would she at least consider to come back for another appointment with you. You ask Katie to avoid any high-risk behaviors, but again, as motivational enhancement, what behaviors should you target? That is up to you as the individual clinician, as well as to the response that Katie or any other individual patient would give you. Katie tells you that she'll consider cutting down and plans to have only 1 drink when out with her friends. You can give her some skills for how to be able to manage that. Often what I will do is tell patients to either alternate an alcoholic drink with a non-alcoholic drink, and then maybe perhaps put a lime or a swizzle stick in their non-alcoholic drink to have their friends perhaps think that they are still continuing to consume alcohol even if they're not. Katie does say that she will come back for another visit to see you. You give her great feedback for not getting into a car with anybody who's intoxicated, and you ask her to try to not have sex when she's under the influence, and she agrees that she will try. You did remember to offer her emergency contraception at the visit, which she declined. To briefly touch on referral to treatment, because it is different in varying communities throughout the United States and the world, it is important to be familiar with available treatment services within the community. In many areas, there's a general lack of adolescent substance abuse treatment that is outside the juvenile justice system. But it is important to know what is available in any individual area. Critical is to treat any co-occurring disorders simultaneously. Many patients are self-medicating, so it's important to use any special caution with stimulant medications for that which might be used for attention deficit disorder. And when possible, to be able to involve parents in the treatment of the young person. However, many families have issues with substance-using parents, and that is how kids got into using substances in the first place. So it is important to keep that possibility in mind. When referring to treatment, it's critical to provide any complementary treatment in other areas, such as vocational training, making sure that there's educational support with school, any other medical concerns or psychiatric concerns to make sure that the young person is getting support in those areas, as well as possibly family counseling or any legal support. It's great if you can encourage a teenager to develop support from any non-using peers, although there are some cautions regarding group treatment. A lot of kids will use group therapies to be able to find other places to be able to use and talk to each other about their using methodology. So important to make sure that that is adequately supervised if there is any group treatment that is occurring. And then always to provide or arrange for aftercare. Once the person, if they need to go to a residential or a long-term day program, to make sure that they are adequately taken care of afterwards and not just dropped back into their previous social setting. This slide demonstrates some co-occurring mental disorders that commonly will occur with patients who have substance use problems because they will often start self-medicating secondary to their psychiatric issues. Anxiety disorders, attention deficit and hyperactivity disorder, and depression are all common reasons for patients to start using substance. Their substance abuse might actually disguise or worsen any coexisting symptoms, so they must be treated simultaneously. Patients will often need special monitoring of attention deficit and hyperactivity disorder meds, which may need to utilize routine drug screens at follow-up exams. Adolescent programs also need to include mental health service providers, both psychopharmacologists, psychologists, and licensed social workers as part of the treatment team. A caution about family and parent involvement. Again, parents may have a role in the origin of their young person's substance abuse problem because the parents have a history of use, so there are genetic and environmental factors that may be at play. Parents may, in fact, have their own substance abuse or dependence, so a family model could be appropriate for that individual young person. Parents' limit setting and monitoring is important to recovery, and in fact, getting parents often into their own therapy program to be able to assist them in better assisting their young person and parenting their young person to get through this may be helpful. This slide demonstrates some different examples of possible outpatient versus inpatient therapies. They may include counseling on an individual group as well as a family level, behavioral therapy, and specifically cognitive behavioral therapy, again, or family therapy, 12-step groups, which have not been shown to work as well in youth as they do in older people, and pharmacotherapy clinics that may include methadone or buprenorphine clinics or the use of naltrexone. Inpatient would include a detoxification center, also possibly an acute residential versus a long-term residential program, which might include a halfway house or a therapeutic school. There are several unproven approaches that many people will often send young folks to, including wilderness programs or boot camps. However, when all else fails, and if you are having difficulty connecting with a young person and moving them through the stages of change and the stages of use, when all else fails, what you can say for them is, I care about you, I am concerned about you, and I will be here for you. When you are ready to address your issue, please come back and see me at any